Okay, so these are my disclosures, and of course, as a radiologist, I have disclosures with imaging companies. This is the blow-up of what Stefano has just shown you. And essentially, if you have a patient with BCR, you need to decide what test to do first, depending on whether you think there's likely pelvic recurrence or likely systemic recurrence. And the parameters are given on the top right there. And it depends on the pathological status, the margin positivity, PSA levels, PSA DT, etc., as you are all aware. If you think it's going to be local disease, then this is a systematic analysis that was published last year, looking fairly and squarely at the performance of PET, fairly and squarely at the performance of MRI. Bottom line is, if you want to detect local tumor recurrence, there's no way Stefano can get anywhere close to me. MRI, specifically multi-parametric MRI, those three techniques combined are superior to PET CT, whether you use choline or PSMA. Why? Because these traces accumulate in the bladder. Okay, so if you have a bladder at the end of successful surgery, quotes unquotes, right, if you still have a bladder, then that big 2 centimeter recurrence can be missed on the PET CT, but you won't miss it on the MRI scan. And you can see the arrows showing you where the tumor is. Okay, so the white arrow in this particular instance, a policeman can see that, so a urologist can certainly see it. As far as nodal disease is concerned, don't come to me, because I rely on size criteria. Stefano wins every single time, but I have USPIOs, ultra small super paramagnetic iron oxide particles. Problem is, I can't get hold of it. It did not go through to licensing. If I had it, I'd be able to spot 2-3 millimeter metastases within normal sized lymph nodes. Now, there are new ongoing phase clinical trials that will report shortly, within a year or two. So by the time of the next meeting, I'll be able to stand here, if Silky still invites me, to say, look, we are better than Stefano for the microscopic metastatic disease. As far as PSMA is concerned, as Stefano has just said, PSMA is better than choline, but choline in most places is more available than PSMA, certainly in the UK. But neither of these techniques are perfect, and we heard about that this morning, particularly at low PSAs. So if you decide that there is local tumor recurrence, before you go to salvage, you're going to have to do some sort of systemic staging. What sort of systemic staging should you do? If you look at the guidelines, the emphasis is still on BS scans, bone scans, I think that means, and CT scans, right? And these techniques are still being emphasized today. And you use them according to clinical parameters, the Sweeney method of doing this, right? But the problem is that clinical parameters really suck. This patient had a radiotherapy. The clinical question was, is this patient got oligometastatic disease? Is he suitable for salvage? That was the question that came to me. Now, this is a whole body MRI scan. I know it looks like a PET scan. I know. It's a whole body MRI scan. Yeah? It's not a typo, right? And you can see this is polymetastatic disease. So your clinical acumen is not as good as you think. That's not me saying this. That paper, and some of you are authors on that paper, clearly identifies that when you think patients have M0 disease, M0, 32% of these patients have metastatic disease. In fact, polymetastatic disease in a lot of these patients. So we have systematic analysis. We have prospective clinical trials. We have meta-analysis that says you cannot do any worse than a bone scan. Yet the guidelines, and I know Nick is on the table, still recommend CT scans and bone scans to take patients forward. And I understand why, but I'm saying, maybe you don't want to do this anymore. You really want to move into next generation imaging. And part of that is whole body MRI. Now, when we met here 2 years ago, I was criticized because there were no standards in whole body MRI scanning. And you know what I did? We said, okay, we will write some standards. Right, so here are the standards. So you can't turn around now and say, my department can't do it because there's no recipe. I don't think so. There's a recipe, it's published, it's a good quality journal, impact factor 14.7, right? Okay? There's no way it is sitting some journal somewhere nobody has ever seen it. So the recipe is there, okay? So we're trying to address that option. So use next generation imaging, whole body MRI or PET-CT with the tracer that you have available. And if you have polymetastatic disease, stop. If you've got oligometastatic disease or M0 disease, then you may want to go back and look at the prostate if you haven't already done so before doing anything else. So here's an example of its usage in real life. So here's a patient in 2012, has oligo-metastatic disease. Where is the recurrence? Follow the red arrow. That's the arrow that tells you where it is. And that lesion was treated with CyberKnife radiotherapy. You can see the plan there. And the patient does fantastically well. You can see that bright spot goes away. So as Oliver said, we got rid of the bright spot. Then we follow this guy. Now this is 2012. And you can see in 2014, 2 years later, he has 2 bright dots that appear with a rising serum PSA. Okay. We do a Choline-PET in this particular instance. We confirm this and we spot weld again. As of last month, this guy's PSA is still suppressed at about 0.7. So yes, he's got a metastatic disease, but we've gone 5 years without starting any ADT. So this is just an example of what we can do. Bottom line, there is no single imaging modality that detects everything. We suggest, Stefano and myself, that you use a stepwise, algorithmic, multimodal approach. Please stop using bone scans and CT scans, particularly when you want to use multimodal treatment that's expensive. It doesn't make any sense. Use next generation imaging, whole body MRI, but don't forget the diffusion, or PET scans, whatever tracer you want, because they uniformly show superior sensitivity for recurrence detection. Which one should you do first? Should you do systemic restaging first, or should you do local staging first? Our view is that you should do systemic staging first and then do the local staging if you find M0 or oligometastatic disease, if salvage is still an option. Thank you very much.